Good afternoon. I'll be presenting bilateral cleft lip repair. So this is a case of a complete bilateral cleft lip and cleft palate with a protruding and malrotated premaxilla. You can see the protrusion and malrotation, complete cleft lip and palate. So the center of the cupid's bow, 2 millimeter on either side, and uh, the white roll being marked. Now 1.5 millimeter on either side. This is the filtral column. So 2 millimeter on the lower end, 1.5 millimeter at the upper end. 2 millimeter on either side of the filtral column. This is to incorporate deepthalized tissue to form the filtral column. Nudab's point and 2 millimeter white roll flap on the left lateral element. This is the vermilion flap and mucocutaneous junction on the lateral element. This is the highest point on the left lateral element. Nudab's point, the white roll flap, the vermilion flap for the vermilion tubercle, and this is the mucocutaneous junction and highest point on the right lateral element. So marking the incision for the anterior palate and the floor of the nostril. Now the mucocutaneous junction in the nostril. The alar rim markings for a open rhinoplasty approach. I do open rhinoplasty at the time of bilateral lip repair. So infiltration 1 and 2 lakh adrenaline. Just reinforcing the markings which are little so the reinforcing the marking it will make it easier for the incisions to be taken. This is tissues to be deepthalized and used for the filtral column. So incising the philtrum. And deepthalizing the tissue lateral to the philtrum. So this deepthalized tissue will be the filtral column. It will augment the filtral column. So that is why we have extra tissue. We are then incorporating it. This is the prolabium being raised. The alar rim incision 2 millimeter behind the alar rim. This is for the access to the lip. Now the anterior palate and the nostril floor mucosa on the middle side being dissected. So here now the the lateral element being dissected, the vermilion flap, the mucocutaneous junction being incised. This is the vestibule mucosal junction of the L flap of the left lateral element. Now releasing the orbicularis oris from the anterior surface of the maxilla and the piriform aperture. So here you can see the anterior surface of the maxilla. Here we are doing a subperistral dissection. This is the piriform aperture. You can see piriform aperture and the muscle being raised. Now dissecting the muscle from the lateral element about 1 centimeter of the muscle being dissected on mucosal and skin side. So incising the right lateral element, releasing the vestibule and the L flap on the right side. Now again dissecting the anterior surface dissecting the orbicularis oris from the anterior surface of the maxilla. Now you can see the infraorbital nerve, so we can go up to the zygomatic arch. Now the muscle being dissected in the lateral element about 1 centimeter from its edge, from the mucosa and as well as the skin. Now raising the nasal mucosa and the vermicular mucosa from the uh, medial side. So leaving behind a strip of vermicular mucosa so that the vascularity is maintained. Now we I routinely do a rhinoplasty in all my bilateral cleft lips. So dissecting the alar cartilages. This is the medial crura being dissected off. You can see the this genetic tissue in between the two crura. So that is what gives it a broad tip. This tissue is being dissected off. The bleeding in the prolabium, you can see, and you can clearly see the vessel that is preserved to the prolabium. This is how the cartilages will come together. Now repairing the nostril floor and the anterior palate with a 4-row vehicle suture. This is on the right side, right nostril floor, anterior palate, and reinforcing it with a L flap. So this is the bilamellar closure. So it will give protection, and the nostril floor being repaired on the left side, and the L flap again to protect the suture line. Now this is the alar cinch stitch. It will move the nostrils close by, and the orbicularis oris will be approximated at the base of the columella. You can see the alar cinch stitch now. This is the most important stitch. Now trimming the pro-level mucosa to develop the sulcus, and this stitch will be taken close to the anterior nasal spine so that the sulcus is nice and high. We have a deep sulcus now. Now reconstructing the orbicularis oris sphincter with 4-row vehicle. The knots are being taken on the nasal side or the oral side. Mucosal. So once we get the sphincter reconstructed, now doing the rhinoplasty, we have dissected the cartilage. Now getting the tip reconstructed, the crura being sutured. This is the midline stitch, lowest point of the cupid's bow, the highest point of the cupid's bow. Now you can see the deepthalized tissue. We have extra tissue on either side. This will give bulk and the filtral column enhancement after closure. So doing the skin closure. So here you can see that the nostril has moved medially, and okay, here we are repairing the vermilion tubercle, the closure of the alarim incisions, all with 6-0 proline. If the patient is from far off, we prefer 6-0 rapid vehicle. So the sulcus stitch. Now you can see the highest point of the cupid's bow, the philtrum on either side, and the filtral tubercle, well formed filtral tubercle, and the sulcus, deep sulcus, and the tip also is better. You have now the nose looking much better than what we started off with. So we put a stent prepared from the suction catheter, 16 number suction catheter, and fix it because while sneezing it might come out. This will be removed at the time of discharge. Now this is the post-op. You can see the nasal shape and the lip, the filtral column, filtral tubercle. Thank you for a patient healing.